Okay, so it looks like we still have several participants that are logging in right now. So we'll just wait a couple more minutes and then we'll start. So we'll give it 2 more minutes. Okay, we'll get started. Hello, everyone, and thank you again for joining us today for the effects of COVID-19 on the illegal drug supply webinar. Today, we're going to hear from 3 speakers who I'll introduce shortly, who will discuss how regulations put in place to prevent the spread of COVID-19 are inadvertently contributing to an increasingly toxic illegal drug supply and how this shift has both increased health harms and created policy opportunities. The webinar will also highlight different perspectives, including systems-level epidemiology data, findings from a local drug checking program, and experiences shared by people who use drugs. First, some housekeeping items. All lines will be muted during this call to ensure sound quality. Please make sure to also turn off your videos. We'll also be recording this video and will be posted on our website at a later date. We will have approximately 20 minutes for Q&A at the end of the meeting. And remember to please submit your questions directly to me during this time. We will take as many questions submitted as time permits. Any questions we can't address will be forwarded to presenters directly for reply. I'd also like to acknowledge that the land on which we gather is the unceded and unsurrendered territory of the Algonquin people. Now for our introduction. Our first speaker is Dr. Jane Buxton, a medical lead for harm reduction at the BC Centre for Disease Control. Jane developed the Intersectoral Drug Overdose and Alert Partnership, DOAP, to respond to provincial issues related to legal drugs in 2011. Jane also led the BC Take-Home Naloxone program implementation in 2012, which has recorded over 63,000 overdose reversals. She is committed to including the voices of people with lived and living experience in developing policy, program planning, research, and evaluation. Secondly, we have Karen McDonald. Karen is Operations Manager at the Centre on Drug Policy Evaluation, which is located within St. Michael's Hospital in Toronto, Ontario. Karen oversees Toronto's Drug Checking Service, a multi-site pilot project that offers collections of samples at 5 of the city's frontline harm reduction agencies, and analysis of samples at 2 clinical laboratories using mass spectrometry techniques. Karen brings over 10 years of public sector experience where she has contributed to health policy and systems change. She holds a Master of Public Policy, Administration, and Law from York University. Lastly, we have Matthew Bonn. Matthew is the Program Coordinator for the Canadian Association of People Who Use Drugs. He's also a National Board Member with the Canadian Students for Sensible Drug Policy and is a Knowledge Translator for the Dr. Peters Centre. Matt was one of the co-founders of Halifax Overdose Prevention Society, which implemented Atlantic Canada's first overdose prevention sites. Matt is also a freelance writer with Bylines and Filter Magazine, CATIE, The Coast, and The Conversation. I'll now turn it over to CCSA's knowledge broker, Doris Bayer, who coordinates CENDU, the Canadian Community Epidemiology Network on Drug Use, to provide some context for today's talks.
Thank you, Nina. Can folks hear me?
Yes.
Excellent. So I don't want to take up a lot of time at all. I just very quickly before we get started, wanted to draw your attention to CENDU, which, as Nina said, is the Canadian Community Epidemiology Network on Drug Use. And for those who aren't familiar, CENDU is a network that CCSA coordinates, and it consists of community partners across the country who collect data on drug use trends in their areas, and then CENDU publishes alerts and bulletins on those trends. And so the way today's webinar came together is that our speakers contributed to our two most recent bulletins, which were on the contaminated drug supply and shifts in the drug supply due to COVID-19. And so the 2 points I very quickly wanted to make was that one, we're looking forward to hearing from the speakers some updates on some of the predictions that we made in our COVID bulletin. And two, if you want to find those bulletins or if you want to receive future alerts and bulletins, you can sign up at the website, which is cendu.ca. So with that, I'm going to hand it over to our CENDU Network co-chair, Dr. Jane Buxton.
Hi everyone, I am just trying to share my screen. I can see Doris.
Hello. I'm not what you want to see right now.
Not what I want to see. So Nina, have you given it to me to share? Perfect. And can people see my screen?
Yes.
Great. I'm just trying to reduce what I can see to make sure that I can actually I was hoping to be able to view my own presentation, which seems to have disappeared. Okay, I will carry on without viewing. I don't know whether or not you can help me here.
Yeah, Jane, would you like me to share yours?
No, I'd like to share mine, but what I want is to get out of the full screen.
There should be a few options at the top of your screen where you can exit full screen. Is that helpful?
That's what I'm looking for, and I'm used to seeing that in Zoom, but I can't see it here. Unless it's, no, it doesn't appear to be there.
If you try to put your screen at the top, sorry, your mouse on the top, it should show up.
I'm under more, and I've got chat, invite, record, those good things. Okay, well, let's get going without.
Jane, did you want me to share my screen instead with with the PowerPoint you provided me?
I'll do it without my notes. Just doesn't quite work as well. Okay, so, well, thank you so much, everyone, for having me to speak today. And as always, I'll be presenting on behalf of many, many folks. So not just myself, but a huge team from the BC Centre for Disease Control, as well as the ministries, people with lived and living experience, and also our partners who are part of the Drug Overdose and Alert Partnership. I also would like to acknowledge that I'm a settler here on a land that I call British Columbia, and it is with gratitude that I live and work on the unceded traditional territories of the Coast Salish people, and that the data that I will be sharing is from 198 First Nations Indigenous territories here in BC. The views I'm going to give are those expressed by me, not by the people who have provided the data, but I just want to give an acknowledgement that a lot of my views obviously have been formed by discussion with people who provide the data and also people with lived and living experience. So my topic today is really looking at a BC perspective and talking about the unpredictable and highly toxic drug supply, why it's happened, what we're seeing. To mention and really the devastation that's happening with regards to the toxicity deaths, paramedic attended overdoses, and what harm reduction measures we've implemented, what our messaging is, and the opportunities. I think as people listening will know, all illicit drug, unintentional toxicity drugs, especially deaths, are preventable. And the figure you can see on the left of this slide, the horizontal line actually shows 5.5 deaths per 100,000 population. That was the highest it had been, and it popped up in 2005 and 2006. 2011, it started to increase, and 2012, and that was when we formed DOPE, the Drug Overdose and Alert Partnership, and also introduced the BC take-home naloxone. And then our public health emergency was declared back in 2016. One of the major contributors to these deaths, as everybody knows, is the amount of fentanyl that's detected, and it's gone from 4% in 2012 up to 85% in 2019. But we know a lot of the interventions have been working, have been averting deaths, and that's opioid agonist therapy, as well as overdose prevention sites and take-home naloxone. And many folks are aware that there's been community action teams, there's been rapid access clinics, as well as increasing treatment centres. So why is this happening? Why has COVID compounded the issues? The overdose crisis has been going on for 4 years, and I think as you saw in that last graph, the actual numbers had declined, still unacceptably high, but had declined over 2019. And people who are impacted by overdose are people who are marginalised, living in poverty, or homeless, or in precarious housing, have food insecurity, unemployed, and use substances. And COVID-19 has come along and has compounded those social and health inequities. And some of the policies around physical distancing leads to challenges accessing services and disconnects people who use drugs from their usual supports. And we know it's so important for people who use substances to be connected, to help them access safe spaces, have positive supports. And this increased isolation and despair can initiate people, they can start to use substances again, or maybe using an increased amount. And the drugs themselves are more toxic. So why is the supply highly toxic and unpredictable? Lockdown restrictions affect production and exportation of drugs and the precursors. And I think we're frequently hearing that COVID actually started in China, and from our enforcement colleagues, we hear that was the main source of fentanyl and other precursors that illicit substances are made from. Drug shortages and price increases have been reported by the community, and we believe there's local production and new dealers coming online, and also there's an increase in violence. We have a number of systems of early drug warning toxicity information, and one of those is drug checking, and that has been reduced in its availability. People have been attending overdose prevention services less, and therefore we haven't been able to have such timely information. And I'm delighted that that Karen will be talking more about drug checking. We also, another source we have in BC is the urine drug screen. So when somebody is on OAT, they get their urines tested periodically, and we get the results of those testing, totally anonymous, but it gives us an idea of what's going on. And also Health Canada Lab informs us of what they're seeing, what's being analysed for enforcement, but they have had reduced capacity. They're also great at responding to our requests if we need something done urgently. And the Provincial Toxicology Lab has received reduced capacity, and that's the laboratory that oversees the testing if we have something urgent. We know fentanyl and its analogues continue to be the major drugs implicated, and benzodiazepines, the etizolam, has continued to increase, and I'll talk a little bit about what we know around mode of use and using alone. What I've done to try and make it simple and easy for people to understand is you'll see throughout my slides when I'm giving you a figure is a horizontal red line, and that's really March of this year when the COVID-19 pandemic was declared. So that because my x-axis varies, it'll give you an idea of where the changes is occurring. So the percent of fentanyl detected in the decedents, what we have seen is an increase in the proportion where it's really high, over 50 micrograms per litre. So you can see that in April and May, it was almost double what it had been previously. And we're lucky to have drug checking, which can corroborate some of the findings that we get from some of the more administrative data. And we know that there are high concentrations of fentanyl in the samples tested, but we don't know whether the drugs were tested for personal use or whether they were presented by a dealer. The novel opioids, we know that carfentanil is much more toxic than fentanyl itself. And you can see on the figure on the left that in June we saw an increase in carfentanil being detected in decedents. And the graph, the figure on the right, which is up until August 13th, you can see how carfentanil had declined over the second half of 2019, but has now started to rise again. What we're seeing on this slide is the results from Life Labs, which I mentioned test urine drug screens. And you can see how when benzodiazepines are identified, the actual proportion that are etizolam has increased to over 60%. So the majority of benzos that are found in the opioid screens are benzos. And then when we look at the drug checking, we have found that 18% of opioids, of samples that are expected to be an opioid, have benzos. So this really reinforces how the drug checking and Life Labs and coroner's data really help to validate the findings that we see across the board. The mode of consumption we've been concerned about, what we saw in our last survey was, and this I think, was a little surprising to us, is the proportion of people who, when they use opioids, are smoking them. So 73% of people who use heroin smoke as opposed to 50% that inject. And 2/3 who use fentanyl report smoking. If we look at the figure to the right on this slide, you can see how back in 2016, injection drug use was the main mode of use in the decedents that was determined, whereas since 2017, 18 and 19, you can see how the orange bar is around smoking. So that was the mode of use determined by the coroner's assessment of the decedents. We also know that polysubstance use is very common, and this really enforces that when we ask the question, what do you use? We had a median number of different drugs and different classes was 3. and that the number who use methamphetamine has increased. Another concern is around using alone, and 76% of the respondents to our survey in 2019 said that they used alone sometime in the past week. And what we're seeing from the coroner's data is that 2/3 of people appear to be using alone before they die. So what a tragic difference a pandemic makes. You can see here how, as I mentioned, that in 2019, we seem to have seen it was flattening, unfortunately still high. But in the last 2 months, in May and June, and it looks as though July will be the same, we have seen this incredible increase in this dramatic and devastating deaths. And it looks as though July will be similar. But who is it that is dying? This slide shows males versus females, and males continue to be more affected than females, and the increase seems to be more for males as well. If we look at age groups, you can see that the 19 to 59 are the highest numbers that are affected, but all age groups have increased. And then if we look at First Nations folks in BC, it's 3.3% of our provincial population are First Nations, but 16% of the deaths that occurred between January and May were First Nations. And you can see here that that's 5.6 times the other population. So First Nations peoples are so much higher, which is very concerning. Changing a little bit, this is some of our ambulance data. So these are paramedic attended overdoses. Again, you can see how that is the highest that it's been. It's increased from March onwards. And we also have information around the ages, and you can see again how similar the 19 to 59-year-olds are the highest that are affected. It's really important how we introduce harm reduction measures and what messaging we have. And overdose prevention sites and supervised consumption sites were designated as essential services. There may have been reduced hours and capacity. Most continue to be open. And our message here is please be safe and use them. Our take-home naloxones continue to be available. Sometimes some of the drop-in sites may have been closed, but you can still access through community pharmacies. Physicians, you may not be able to have your face-to-face appointment, but there's been a lot of telemedicine and internet connection with physicians. And another message we've really highlighted is if you can't use an OPS, buddy up. Make sure you're using with somebody who can respond. And we do see that there have been challenges with regards to guest policies. Guest policies which reduce people attending have really helped people feel secure, and people who are concerned around COVID and avoiding people around in the province, in the hotel. But it also may have restricted access to people being able to use with a friend. I think what we have seen is the incredible amount that people with lived and living experiences have stepped up and have provided additional services, have wanted to provide resources on how to respond, and they are the forefront of some of our responses to the overdose. This is a slide that shows our overdose prevention sites and supervised consumption sites in BC, of which we have 32 currently. There are additional ones that are attached to particular supportive housing, but these are the ones that are run through the health authorities. And you can see the numbers were declining even before COVID started. And we have to bear in mind that the number of attendances, there may be some that are missing. It may not be quite as low, but this certainly tells us that there has been a decrease. If we look at the number of overdoses survived, so obviously if there's less people attending, the numbers are less likely to have an overdose at the sites. And again, you can see the numbers where people have overdosed at a site and been responded to have gone down. And just to emphasize that we have had no overdose death at an overdose prevention site or a supervised consumption site within BC. And going back to that last slide, you can see how many visits there were going on as a norm and how that's actually come down by about 50%. Take-home naloxone kits have continued to be shipped out to the sites. You can see here, this is to all of the sites, and I broke this down looking at pharmacy and non-pharmacy, and there hasn't been an uptick in the numbers using pharmacy. It looks as though they're still being shipped to and ordered from the community sites as well. And this just shows a decline in the number of clients that are dispensed OAT within BC. Again, a slight decline over since March. So rather than just sharing some of the challenges and some of the unfortunate occurrences that have come out of COVID and this collision of the dual crises, public health emergencies, I also wanted to share some more opportunities that have happened. And what we've been seeing is there's increased support for peer-led initiatives, more outreach, more overdose prevention sites being opened, more inhalation overdose prevention sites being opened, including at places where people have been offered accommodation at hotels, so have been moved from encampments into hotels, many of which have overdose prevention sites. And the people with lived experience are the people who are really helping support many of those initiatives. We've seen an increase in social assistance payments, and this has hopefully helped people to be able to afford safer housing, to afford food and nutrition. And it's also the dialogue has returned around a basic guaranteed income. So some of these changes hopefully will continue after COVID is not such a high priority issue. Health Canada exemptions, this was initiated, and they announced, and what this has involved is actually accessing the provinces having more control over the supervised consumption sites and the overdose prevention sites and other initiatives. And just recently, they've announced an intent to develop new supervised consumption regulations, and their feedback is being sought until October the 14th, so people have an opportunity to feedback there. In BC, we have a number of initiatives, and I'll just talk a little bit about these. The first is the risk mitigation interim guidance. And this is looking, it can be termed pharmaceutical alternatives to the toxic drug supply, but really it's to address withdrawal for people who, to help people remain in quarantine and isolation and not to be having to approach or go to the pharmacy quite so frequently, not to be on the streets and purchasing their substances and interacting with many people. So this has included having dilaudid, hydromorphone and Eslon available, and also other benzos and stimulants that may be prescribed, as well as managed alcohol programs. But I just wanted to emphasize this is not safe supply. This is really to address withdrawal in the light of COVID happening. But along with this has been the ability for pharmacists to extend prescriptions, to repeat prescriptions, to deliver to people, again, to reduce the need to go out and to help people maintain that physical distancing. And this has obviously initiated conversations which we hope will continue and will be part of an ongoing safer supply discussion. Another initiative that was introduced in BC is the Lifeguard app, and this was launched in May of this year. And you register using your phone, and before you use, you just put in your first name, any details of where exactly you're going to be using, whether it's in the bathroom in a particular place or whether your apartment is on the 4th floor. It does have GPS, so people can, the emergency services do know roughly where you are. And then you put in the substance that you're planning to use. You press the start button, you can pause it and then press again. And once it gets to a minute, the button on the phone starts flashing. If you don't cancel it, it gets louder and it flashes and it starts vibrating. There is no information that is shared unless the alert goes off. And it goes through BC Emergency Health Services. It doesn't go through 911. So it still works even if there is no 911 available in a rural area. And to date, there was, up until the beginning of August, there were 10 calls where the emergency responders had responded. And the next slide is really, because of all that's happening, we've had some announcements from our Ministry of Mental Health and Addiction. Firstly, there was a $10.4 million announced in August the 4th, which is to open more supervised consumption sites and new inhalation sites and to fund inhalation supplies and more staff as well. And then just more recently, there was 36 million announced for 3 years for 123 new youth beds. So this is what I've covered, and we obviously will have our next 2 presenters, but just to highlight that we've done a lot of things, but we need to do more. We need to talk more about decriminalisation, and we also need to tackle the problem of prohibition and what we can do about it, and also safe supply. So I will now hand over to our next presenter. Thank you for your attention, and we'll have questions at the end.
Just 1 second. Oops, not that. Okay, I hope everyone can see my screen and hear me. Just gonna move
Looks good.
Thanks. Okay, so as mentioned, my name is Karen and I work for the Center on Drug Policy Evaluation, which is the organization that is coordinating and also evaluating Toronto's drug checking service. Before I get started, I just wanted to thank the CCSA and specifically Nina and Doris for hosting this webinar and also for including us in it. In terms of what I plan to cover today, I'll give a little bit of a background on what drug checking is, and then get into our project here in Toronto, and then also talk a bit about the impact of COVID-19 on people who use drugs in Toronto, our service, as well as the unregulated drug supply here in Toronto. So in terms of what drug checking is, it's a free and anonymous harm reduction service that allows people who use drugs to submit a sample of their drug to be tested, and then they receive results along with tailored consultation. It's something that's been in use in Europe since the 1990s, and it's risen in popularity here in Canada just over the last couple of years, I think, in response to the overdose crisis. So in Europe, generally it's been found more amongst like kind of recreational or nightlife and party settings, whereas in Canada, the project that I am going to talk to you about today generally applies to a different population, which is people who access overdose prevention or harm reduction services. And again, the goal is more focused on overdose prevention. So there are now drug checking services operating throughout the country, all using kind of varying models. And I would say that the models all kind of have their trade-offs in terms of the quality of information they can provide, the timeliness of information, as well as the cost. So our project has a number of goals, and I've just kind of highlighted a few of them on this slide. So primarily, we're trying to target people who use drugs in Toronto and provide them with timely and detailed information on the contents of their drugs. We're also sharing regular information on Toronto's on Toronto's unregulated drug supply. And the primary kind of purpose for that is to inform clinicians as well as harm reduction workers so that they could tailor the care that they're providing to people who use drugs, and also informing research and policy. And then lastly, we are evaluating our drug checking service to determine whether or not it results in a reduction in overdose and other harms, and whether it's a valuable harm reduction service here in Toronto. So before I get into who our partners are, there's a few things that I'll explain about our service. So the first is that it's a pilot project. So we have about 3 years of funding. So we'll be implementing until approximately the end of 2022. Our funders are Health Canada's Substance Use and Addictions Program, as well as the St. Michael's Hospital Foundation. And our project operates by way of exemptions from Canada's Controlled Drugs and Substances Act. We have a bunch of partners who are kind of working with us on this project. We do have a community advisory board made up of approximately 10 people who use drugs here in Toronto, who consult on the design and execution of the service. We've then partnered with 5 harm reduction agencies that are collecting samples and communicating results. We've partnered with 2 clinical laboratories that are analyzing samples. And then we have a kind of a variety of other community, government, and research individuals and organizations that we've partnered with. In terms of our model, there are really 3 main groups who are kind of, who participate in drug checking. There's the client, the harm reduction agency, and the lab. So what happens is a client wishes to have their sample checked. They'll bring that sample to one of the 5 participating harm reduction agencies where it will be collected. 5 days per week, we transport samples by bike courier to one of the 2 participating labs. And at the lab, samples are analyzed using gas or liquid chromatography mass spectrometry. Results are then emailed back to the site that collected the sample, and then those results would be communicated with clients along with tailored harm reduction strategies, providing the client wants that information. So since we're not collecting and analyzing samples at the same site, our model is what's known as off-site drug checking. In terms of accepted samples, we do accept substances or paraphernalia after it's been used. So we accept a small amount of powder, up to kind of 10 milligrams is what we're asking for, or a small bit of a pill, or some of blotter, or a small amount of a liquid. Alternatively, paraphernalia after it's been used could be checked. So that would include a filter or a cooker, or leftover liquid from a syringe. In terms of the information that we're providing with the results, we're providing both qualitative and quantitative information. So qualitative information is what drugs were found in the sample that is checked, and then the quantitative information is how much of each drug that was found is present in the sample. So certainly the quantitative information is very important, and we're kind of improving the information that we're providing on the quantitative front over time. And then we turn results around generally within, by the next business day. So that's kind of it in terms of what our project is. Then what we've done here is we've just kind of outlined some of the challenges and some of the emerging solutions that people who use drugs are kind of facing amid COVID. So in terms of challenges, certainly there has been a significant increase in overdose fatalities. So in June, the coroner here in Ontario released some preliminary data to show that between March and I think it was May, suspected drug-related deaths were up by 25% in comparison to kind of January and February of 2020, as well as every other month last year in 2019. And then just last week, Toronto Paramedic Services actually released some data to say that opioid-related deaths in the city of Toronto are up by 85% from March to July. and that's in comparison to the average amount of opioid-related deaths any month in 2019. So very significant increases on that front. A second challenge is barriers to accessing harm reduction services. So at the beginning, when the state of emergency was originally declared in Ontario, there were some site closures. Some of the harm reduction agencies did have to close in order to get infection prevention measures and protocols in place. Since then, a lot of the sites, I think all of the sites are open again, but they have been, they have reduced capacities in an effort to meet physical distancing requirements. So that's certainly been a challenge. And then lastly, there have been some operational changes at some of the sites that have kind of made accessing these services more challenging. So for example, requiring clients to book an appointment before using the service. And then of course, another challenge that we've indicated is heightened concern about people using alone, because with less people, leaving their houses and going out, that's definitely something that's been a concern and a challenge. So in terms of the emerging solutions, I said policy changes or kind of changes to regulation. So some of these Jane actually mentioned. So the first is very early on, the federal government made available class exemptions to each of the provinces and territories, which would allow the provinces and territories to open overdose prevention sites at their discretion within their province or territory. And in that class exemption, other harm reduction services like drug tracking were included. So usually what would happen is if a site wanted to offer supervised consumption or overdose prevention, they would have to get approvals from the federal government since it falls under their jurisdiction. But because of COVID and just knowing that we maybe would have to get these sites up and running more quickly, the feds made the class exemption available just to kind of reduce the administrative barriers that are associated with acquiring exemptions. So unfortunately, as far as I know, I think the only province that has actually participated in the class exemption at this point at least is British Columbia, but that is something that's been made available to everyone. Additionally, the federal government has adapted regulations related to prescribing controlled substances for substance use disorders and chronic pain. So with that, we're starting to see changes to clinical guidelines around prescribing, and we're also starting to see some changes by clinicians in their prescribing. So for example, making carries or take-home doses of opioid replacement treatments available. And then lastly, on the emerging solutions front, there have been some funding opportunities that have been made available. So for example, I know several of the harm reduction agencies here in Toronto have received funding to provide prescribed alternatives to people who inject opioids. In terms of kind of the impacts on our actual service, we have been very fortunate in that we've continued to offer drug checking like throughout COVID. There was really no interruption to the service. That's not to say that people who use drugs in Toronto didn't have trouble accessing it, but it has remained available, which is really great. So this slide shows, or this graph I should say, shows the number of samples that we've checked since we launched our service in October. So we've checked just under 1,000, and the pink box highlights those that have been checked since the state of emergency was declared in March. So you can see that, you know, as soon as the state of emergency was declared, basically the number of samples that came in just plummeted. I think we had approximately like 35 samples coming in the weeks before the state of emergency and then was declared, and then after it was like less than 5 samples a week. So we've kind of spent these months trying to, you know, build back up the number of samples that are coming in. And then actually just over the last few weeks, we saw like a real spike in the number of samples that we've collected. And it's actually now surpassed where we were before COVID. This is partially because we brought on 2 additional collection agencies during COVID too. So in terms of changes to the unregulated drug supply, It's a little early to start making any real calls about trends, but there are some observations that we've made that we wanted to share with you. So there's a lot happening on this slide, but I'll try to explain it the best that I can. So as I mentioned, we've checked almost 1,000 samples since October. 453 of those samples were expected to be fentanyl. So what that means is when a sample is collected, the drug that that sample is expected to contain is recorded. And so for, you know, almost 50% of the samples we've checked, the expected drug has been fentanyl. This graph shows the presence of fentanyl and what we define as unexpected noteworthy drugs in expected fentanyl samples. So as it says on the slide, we define noteworthy drugs as drugs that are highly potent or may be linked to overdose or other adverse effects or may not be desired by some clients. And again, the pink box kind of highlights the samples that have been checked since the state of emergency here in Ontario. So, oops. Sorry. So kind of just going through these. So the yellow line indicates benzodiazepine-related drugs found in expected fentanyl samples. So that's something that Jane was referring to as well. So what we've seen is that since the state of emergency was declared, the number of samples that the number of fentanyl samples, sorry, that benzodiazepine-related drugs are presenting in has increased. So we're now seeing benzos present in an average of 40% of all of the expected fentanyl samples, which is slightly higher than it was pre-COVID. And in fact, in the last couple of weeks, it's like, I think over 50% of samples that we're seeing contain one or more benzo. So this is primarily atezolizumab, but also some other benzodiazepine-related drugs like flualprazolam and flubromazole. And the reason that this is noteworthy is because in combination with opioids, benzodiazepines increase or can increase the risk of overdose through respiratory depression. So kind of moving along, the purple line that's kind of closer to the bottom here, this is active fentanyl-related drugs that are active. And you can see that they're really starting to, the presence of those in fentanyl samples is also really starting to grow. And the reason that this is noteworthy is because it could mean that fentanyl samples are actually more potent depending on the quantity of fentanyl and the quantity of the active fentanyl-related drug that's in there. And then the last one that I'll just focus on is the kind of green line here at the bottom, which is synthetic cannabinoid-related drugs. We've also seen an increase in those in expected fentanyl samples since the state of emergency was declared. And so synthetic cannabinoids are manufactured to be like THC, but they're generally much stronger. So this is an alert that we put out in June, which was related to a new to us synthetic cannabinoid called Acknowledgement. And as far as we know, Acknowledgement hasn't been found mixed with opioids anywhere else in Canada, or hadn't at that point at least. So the presence of synthetic cannabinoids is noteworthy because when taken in combination with opioids, they have been known to suppress breathing and other vitals during overdose situations. So a lot happening with the supply and a lot of kind of, you know, things that we find noteworthy and that could really kind of explain the increase in overdoses. So quickly before I summarize, I just wanted to put in a little plug for our new website that we've actually just soft launched today. So the URL is here on the screen. I'm just going to flip over to it quickly, I think. Oops. 1 second. Oh. Sorry. Okay, I just shared the link in the chat box as well. So, smooth transition, sort of. Okay, so as I mentioned, we have just today kind of soft launched this new website for our drug checking project. And it's definitely a work in progress. There may be some bugs and some errors with the data, but essentially we're going to use this site to communicate alerts and reports and other information on Toronto's unregulated drug supply. So the main feature of this site is these interactive graphs that will be used to kind of communicate learnings about learnings from samples checked. And so I would just kind of encourage you to poke around, and if you want to provide us with any or all feedback, we would really appreciate it, because we're just trying to get this thing off the ground, and we'll be kind of iterating and hopefully making it better over time. Okay, back to this. So in summary, there are just a couple of things that I indicated here. So first, COVID-19 has deeply impacted people who use drugs in Toronto. I think this is most evident by the significant increase in drug-related deaths that we have seen. Secondly, harm reduction services are fragile and require long-term coverage solutions. So I think that we have seen just like how devastating the effects could be if harm reduction services were not available. And so these services definitely need to be sustained, and long-term coverage options are certainly required. Third, creative and collaborative policy responses are essential. So this includes, you know, the availability of and participation in things like class exemptions, as well as decriminalization for possessions of all drugs for personal use. And then lastly, I think you know, I think that drug checking has proven that it is valuable here in Toronto, especially during COVID, at the kind of individual level, as far as, you know, giving people information about what it is that they're using, but also just in terms of us kind of in real time being able to see changes to the supply. So that concludes my presentation. Thanks so much for listening, and I've included our email address here as well as the URL to our website, and I look forward to answering your questions.
Hi everyone, can you see me and see the slide? Karen, I'm looking at you because you're the only person I can see, so.
Yep, I can see it.
Okay, cool. Hi everyone, my name is Matthew Bonn. I'm the program coordinator with the Canadian Association of People Who Use Drugs. Just want to thank the Canadian Centre for Substance Use and Addiction for asking me to speak, and thank Karen and Jane for presenting before me. First and foremost, I'm going to do a land acknowledgement that is very specific to Nova Scotia. I'd like to acknowledge that I am presenting today from Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the Treaties of Peace and Friendship, which Mi'kmaq and the Wolastoqiyik Tuwiki signed with the British Crown in 1725. The treaties did not deal with the surrender of the lands and resources, but in fact recognized Mi'kmaq and the Wolastoqiyik Tuwiki title and established the rules for what was to be an ongoing relationship between nations. Honoring this treaty relationship through a land acknowledgement is just one of the many steps that can be taken towards reconciliation, as outlined in the 94 calls to action issued by the Truth and Reconciliation Commission of Canada in 2015. We completely believe that every individual and every institution has a role in making the needed changes to dismantle systemic racism and oppression against Black and Indigenous people in Canada and around the world. We think one action that anyone can take is raising your own cultural awareness, learning about other cultures, asking questions, reading, and becoming more self-aware. Seems simple enough, but we go into the process being prepared to be humbled at any point, because we are entering a lifelong journey and we will make mistakes. We must keep an open mind and open heart. Through this acknowledgement and the harm reduction philosophy, we commit to ourselves to lifelong work in creating an effective change within our society. So this is kind of my presentation layout. I'm gonna kind of talk about the current state of the overdose crisis and the drug market in Canada right now. The Canadian Association of People Who Use Drugs, at the beginning of COVID, did a drug market survey and had informal conversations with KPUD members across Canada, and we have some qualitative and quantitative data from that. Speak very briefly about kind of safe supply versus safer pharmaceutical alternatives and why we need to push for both. And as well as, some of the innovative harm reduction interventions that have come from COVID-19, overdose prevention hotlines, online drug checking resources, the MySafe Society, and a little plug for our urgent public health needs like community of practice. My slides aren't working. Oh. So the current state of the overdose crisis is supposed to kind of come different than this, but if you look at the media headlines that kind of have taken control of these dual pandemics, we have a lot of, Toronto had recorded 27 suspected overdoses in July. June was the worst month in BC history for overdose fatalities. Warnings about contaminated drugs, sons dying from overdoses. I couldn't find enough media headlines of how the COVID-19 pandemic clashing with the overdose crisis has really impacted people who use drugs. Where we're seeing in Saskatchewan and Regina and Saskatoon, kind of the crisis take place there. We're also seeing it in Nova Scotia. We had a 15-year-old girl that recently died from a fatal overdose from MDMA, potentially cut with fentanyl. And I overdosed a couple weeks ago, and luckily I survived it. But this crisis is going around all over us. So the current state of the drug market. This is from a bust on May 6th in Vancouver of 20 kilograms of fentanyl, and there was guns and cocaine and crystal meth and cannabis. So this was a 4-month investigation that led to this bust, but this was still happening after the pandemic. Public health regulations and recommendations were at the peak around May 6th. In Nova Scotia, there was a bust of 270 kilograms of cocaine on July 17th. Ironic about this case is that somebody called the tip in because they thought somebody was trying to sneak in unnoticed to kind of bypass physical isolation and quarantine, and then they ended up busting a huge kind of this is a huge bust for anywheres, resulted in approximately $33 million of street value of cocaine. So as you can see, people who use drugs, people who are engaged in kind of drug production and distribution are innovating and adapting to the pandemic, and they will continue to kind of continue to manufacture drugs and to import drugs in different ways. They'll be more deadly and more fatal. So we have to, utilize all the resources that we have. So this is our informal discussion with KPUD members. So at the very beginning of the pandemic, we created a Google survey. We really wanted to know what was happening on the ground with our members and in our country. You can't really do that in the online survey. So we had an option to follow up with members, and we had an informal discussion with willing participants for about 30 to 40 minutes to get them to elaborate on some of the questions they answered. I want to state some of the limitations of this survey. There's this huge digital divide. Some people don't have access to internet. We will never reach everybody with online surveys and online engagements. We have to keep that at our forefront. And how can we change the way we do things to meet the people that aren't going to be engaged through internet? The questions in the survey could have been expanded on a little bit, and having about 10 to 20 more people would have been ideal. We've had 29 people fill out the survey and do interviews. So if we would have had around 50, that would have been fantastic. So our geographical representation, we had people from coast to coast. You know, we still are missing out in some of the territories, and that's, you know, some of the work we need to do to engage people who use drugs in those, in that location in the north. But, you know, it was really nice to see that we did have people in each, almost every province. We didn't have anybody in Newfoundland for this particular survey. A lot of engagement in Manitoba. We've been doing some work with the Manitoba Harm Reduction Network, so it's nice to see people get engaged in areas that we have not always had engagement. So the general demographics for the gender identity, 58.6% were cis female, 27.6% were cis male, 6.9% were non-binary, 3.4% were trans androgen, and 3.4% another participant was a female that identified as somebody in the LGBTQ community. The ethnicity, we had 55.2% of the members were Caucasian, 34.5% Indigenous, 6.9% had mixed ethnicity, and 3.4% were Métis. The age category, we had the majority of the participants were between the ages of 25 and 44. The next to that were 45 to 59. I don't have the exact numbers there, but I think we had one person that was 18 to 24, one person that was 60 and over, and the rest were in between. And we always ask our members if they live in an urban and rural setting, because it has such an impact on the services that may be offered to them. We had 86.2% in an urban setting, 13.8% in a rural setting, and that's no surprise, as a lot of the engagement was through internet and online engagement. We asked members what their preferred drugs were. These are people who are current or former drug users. I believe the majority of them were current drug users. And it ranged. There was all kinds of different substances. A lot of people said fentanyl, a lot of people said cocaine, heroin was up there, crystal meth, and then ketamine, some psychedelics, cannabis. But the majority of participants said fentanyl, cocaine, and crystal meth. So we asked the members what the biggest change in the drug supply was based on their perspective. So we asked all 29 participants to select all that applied to them, and we had an other category. So we had 21 people said that availability was a big issue. 18 participants said price was an issue. Right next to that was accessibility with 17, and potency with 14. And the reason why we have availability and accessibility, because, you know, just from personal experience, the drugs may be available, but now with public health recommendations and, you know, not being able to move as freely or to travel, sometimes you may not be able to access the drug as you would be able to prior to COVID. There was a lot of fear of criminalization. You know, this came up a couple times. We didn't see a lot of it, but it did come up a couple times. This isn't something that we had as a box. Like, this is they put it in manually. So, you know, a lot of people are worried that they're going to be arrested more so because of COVID and that they use drugs. This one's kind of shocking to me. We asked if members were forced to go through involuntary withdrawal. Out of the 29 participants, 9 of them were forced to go through involuntary withdrawal. and this shouldn't be happening. As Jane said, the risk mitigation guidelines are for withdrawal, and members, citizens, people who use drugs, they should not have to be going through involuntary withdrawal with the medications that we have available now. This is another one as well. How do you acquire your drugs? So we asked 3 different things. We said the street, the prescription, or both. So not one person said they only received their drugs through a prescription. 41.4% said they received them on the street. 58.6% said they received them through a street and a prescription. But this shows that everybody who is using drugs that we talk to is still at a risk of a contaminated poisonous overdose, and we have to get this number down where more people are just accessing safer pharmaceutical alternatives and not being forced to go to the street. So we asked members as well about their personal drug use habits changing, and we've had different answers. We had 12 participants that said their drug use is increasing. 4 participants mentioned things around more using alone, using fentanyl, and they wouldn't typically be using fentanyl, so more different unsafe using practices. 3 people just said their drug use changed. They didn't specify how. 3 people were accessing safe supply. 3 people said it was the same. 2 people said they relapsed after a period of abstinence. And 2 people said their drug use decreased due to COVID. So here's some quotes from participants. Have been using a lot more unsafe drugs, also trying to fill that void with other medications. This one really hit me hard. It's been harder to get the same amount I used to get for $60. I have OD'd twice due to supply, been contaminated playing games of Russian roulette anytime I buy. I got safe supply, but feel like the dosing not right, still needing to use illicit just to get by, and it's not injectable. Taking pills is just not the same. Trying to balance safe supply, mixing with illicit fentanyl. I had to give up benzodiazepines, not by choice. It was horrible. The pills just weren't available for a decent price. People should be getting prescribed benzodiazepines, getting prescribed medications that they're on. It has been more difficult to find drugs during this pandemic, and as I don't have access to testing tools, I am more at risk because I've consumed drugs from new, potentially dangerous sources. So those are some of the qualitative quotes that people we heard from people in their discussions, or they typed them and sent it in to us. I think we really have to look at people are on safe supply, but they're still being forced to buy from the illicit market. But we have to people shouldn't be going through withdrawal involuntarily, and they need access to drug checking and other innovative harm reduction measures. So we all deserve a safe supply of drugs, and I always like to say this because everyone really has the safe supply of drugs until you're somebody who uses drugs, and then you are forced to either go on to opioid agonist therapy or different variations of medications that you don't want. And I think if somebody was on a high cholesterol medication and they had to go daily to get that medication, and they had a safe supply of that medication, and it was a life-saving medication, and then all of a sudden you notice that they're taking 2 of them, or whatever the reason were, and you kind of strip that medication away from the person. This happens to people who use drugs all the time. And as soon as you kind of get labeled with the opioid use disorder or substance use disorder, you never get really looked at by doctors the same way again. And we are lucky that we have some great doctors working in the field, but people who use drugs deserve a safe supply of drugs as well. So Kaput defines safe supply to a legal and regulated supply of drugs with mind or body altering properties that traditionally have been accessible only through the illicit drug market. In a perfect world, this would include diacetylmorphine, cocaine, fentanyl, and all drugs people use for recreational purposes. We're not there yet, but we got to continue to push for it. So we have safer pharmaceutical alternatives such as hydromorphone, diazepam, and dextroamphetamine. I can never say that word. Is the only alternative we have until regulation of all substances comes into place. And, you know, with our current government, you know, this isn't going to happen anytime soon. We got to continue to push for it. But people with any kind of, you know, power and privilege of prescribing people a safer supply of drug need to start enacting that and start using that privilege to, you know, prescribe somebody with a safer alternative, not forcing them to go buy a contaminated supply. And we have to continue to do this. You know, we can't wait for, you know, a holistic safe supply and say, well, I'm not going to prescribe a safer pharmaceutical alternative in the meantime. They have to go hand in hand. We have to be pushing for them both, and we have to implement safe supply programs up all over the country, not just in Toronto, not just in Vancouver. They need to be in every community health center, every province, every territory. The one kind of silver lining I think that may have come out of COVID-19 are some of the innovative harm reduction measures that have been taking place. As I mentioned before, that digital divide is always going to be a barrier to people. Some people just may not have the, you know, the function or the capacity to engage in Zoom meetings or online teleconferences all day, or any kind of service delivery that is only offered through a telephone or a computer. So we have to be innovative. But we, you know, we have seen a lot of these interventions. We're seeing telemedicine for treatment for mental health and addictions, including opioid agonist therapy. As somebody on OAT myself, you know, I love just having to see my doctor by telephone. I don't have to do urine drug screen. I still get my weekly carries, and I actually have a great relationship with my doctor. I had a great relationship with him prior to, but you know, this has provided a more patient-directed way to provide mental health and addiction services. We have overdose prevention hotlines and overdose prevention apps that Jane spoke to, and you know, these can be implemented without really any systematic or big organization. You can implement this with you and one other person and a telephone, or I guess 2 telephones. You know, when I used fentanyl right at the beginning of the pandemic, I called a close support to mine and had them on FaceTime. I used the fentanyl, and you know, I waited 5 to 10 minutes until, you know, I could feel the effects, and then I hung up with the person. And these can be implemented by anyone at any time, and you know, as long as one person knows that you're using and where you're using, you have that much better of a chance to, you know, successfully be responded to if you do overdose. And we have, you know, we have a lot of new innovations happening. We have verified identity dispensers, the MySafe machine, which is getting ready for a national rollout. So I wanted to mention about getyourdrugstested.com. Here in the Maritimes, we don't have any drug checking services. We don't have, you know, our provincial government has yet to even support the qualitative dipsticks for fentanyl testing. So like the one alternative we have is to send our drugs away to getyourdrugstested.com. You can email them at this email right here to get their mailing address. Place approximately 10 milligrams on the streets. We call it a point. So a point or 2 or more of the substance to be tested into a small plastic container. They want it triple sealed, and so they ask for a $5 donation if you can afford it. If not, they're not going to not test your drugs if you don't put that in. You send it to them. When with COVID, it has, you know, it varies in times of when they may receive that substance, but you write down on a piece of paper what you think the substance is, so what it was being sold as, a description of the substance, and your email address. This to me is really kind of for people engaging in low-level drug dealing and kind of at that mid-level to keep their, customers and clientele safe. So this is what it looks like. I took down all the results from Halifax in the month of June. So these are people that sent in drugs from Halifax to get your drugs tested in Vancouver to see what their drugs were in. So the last one we had June 30th, 2020, Halifax. It was a white powder sold as an NEP, and the result, it was an NEP. We'll look at a different one here. So there's white powder. The person didn't know what it was sold as, and it was cocaine. So, it's pretty straightforward. It gives you a test, when the date was tested. And since the pandemic, I have noticed a lot more people in the Halifax area utilizing the service. And, hopefully one day we can have something like this here locally, but until then we can send it away. The MySafe project. So the MySafe is a safe supply initiative formed in response to the overdose crisis, providing people with a safer, regulated supply of opioids to prevent overdoses. The MySafe, as I just mentioned, is launching a national rollout with 5 more machines. The locations are going to be in Vancouver, Victoria, London, and Dartmouth. These machines are practical prior to COVID-19, but with the pandemic, they just serve so many purposes. I really do see these machines as ATMs and banks, and they will be in every pharmacy one day eventually, where you can just go and get your medication without having to go to the back of the pharmacy in the middle of a pandemic where everyone's sick and coughing and sneezing on each other, and you can kind of get your medication without any contact between a person. And Kaput is thrilled to be one of the locations for the national rollout, and more will be revealed on that. So this is one of the MySafe machines. You can see kind of the external camera it has there, the biometric vein reader. So it scans your veins in your palm, which is actually more bulletproof than like a fingerprint, so it's more identifiable. So this is kind of the outside, what the machine looks like, and it's a very safe, I like to describe it as like a community kind of contactless lockbox where, people that are in shelters or, precarious housing situations that typically may not been able to get their carries or to be on a medication or a safe supply medication can go to a machine like this and get it in a safe alternative way. And, the MySafe Society has been pretty vocal that, they have an alternative, and, we need to be implementing these machines and a safe supply with them to all the provinces in Canada. Whoa. Can you see it? And last but not least, we have an urgent public health needs site community of practice. This is a community of practice done by the Dr. Peters Center for Health Canada, and we meet bi-weekly. If you want, you can go to the website. It's UPHNS. You can click on the slide. So if CCSA is going to share the slides, all the pictures, you can click on it and it'll be linked to your website. But we meet twice a month to talk about different, solutions around urgent public health needs sites and overdose prevention sites, safe consumption sites. We were mentioning on our call before that, there's now that the provincial governments can exempt locations, there really are no protocols to exempt them, and you kind of are forced to go to the federal government to discuss how to get an area exempt. So these are some of the things that we are troubleshooting through a community of practice, and it brings a lot of like-minded people together to discuss how we can advance harm reduction in Canada. And, I just want to say kind of urgent public health responses that we need are safe supply and safer pharmaceutical alternative drug checking services in all provinces, federally funded overdose prevention sites and safe consumption sites in all provinces. And the reason why I say federally funded is because we continuously have problems with provincial governments trying to, or not willing to be able to fund sites. We need community-based detoxing, affordable housing, and soon, hopefully, decriminalization and regulations of all drugs for recreational purposes. And I always like to end off my presentation with this slide. It's a Banksy photo. Keep your coins. I want change. And change is what we need. Thank you.
Thank you so much, Matthew. This has been a very insightful and very helpful webinar. Let me just take a look in here, make sure that the screen. Perfect. Again, thank you everybody for sharing your resources. I've received several messages from a variety of people asking already for your PowerPoint slides. So yeah, that would be fantastic. I'll definitely be sending this out shortly. So we'll go ahead now and read some of the questions that have been provided by our participants. Let's take a look-see here. Okay. Are you guys able to see me? Oh. Hi, everybody. Are you able to see me?
Yep.
Perfect. Okay. Fantastic. Okay, so first question that we have here is for Karen. Do you have any data on whether behavior changes with the results of the drug checking?
Hey there. Yeah, thanks for this question. We do have some data on that. So when we collect samples and also when we share results, we do administer some questions to clients who choose to participate in the evaluation. So some data that we pulled recently showed that just over 30% of respondents disclosed that they intended to do something different after using drug checking. So that could mean kind of a number of things. It could mean that, they decided that they're going to use at the supervised consumption site instead, or that they're going to use with a friend, or that they're going to give feedback to their supplier, or it could mean something so extreme as like they're not going to use the drug. So yeah, about 30% so far have been indicating intent for some type of behavior change.
Thank you. Next question, just going to go through them fairly quickly. What are some examples of fentanyl-related active drugs?
Yeah, so the main fentanyl-related active drug that we're seeing is acetylfentanyl. So that is a fentanyl analog that I think is about 30% as potent as actual fentanyl. So that's the one that we're definitely seeing present the most. We also are seeing, and that's actually just kind of recently, there's kind of been a spike in that. We also do see some carfentanil, but not a lot, and not a lot recently. I think carfentanil has presented in like 1% of expected fentanyl samples checked.
Thank you. This is another one. How much is your annual funding for drug checking? And again, that's for Karen.
So we received $2.5 million between the two, between Health Canada and the St. Michael's Hospital Foundation over 5 years. So as I said, for 3 of those years we'll be implementing. So I think our budget when we're kind of fully implementing is about $650,000 or so per year. And that money pays for, some central resources, but we also buy a half-time staff member at each of the harm reduction agencies. We buy a half-time lab technologist at each of the labs. We pay service fees associated with every sample checked. We have our courier and that type of thing.
Thank you. This one is for everyone. How do you advertise these innovative services, such as the drug checking and the new Safe Use app for smartphones? It seems like such advertising isn't in the mainstream, which could lead to reduced uptake and use.
I think for that one, it's extremely important to be advertising those through local harm reduction organizations that already have trust and relationships built with a large majority of the people who use drugs, if it's through flyers, if it's on outreach, if it's on cards. But, I think needle syringe programs, safe consumption sites, OAT clinics, they really need to be pushing these services, and they need to take them on and adapt them into their service delivery. I think, having a phone call or an app keep you safe is just so, just makes sense. And they really need to step up and start offering these services locally anyways.
There's another question regarding the app, and so sorry, I think it's echo. It says in here that in regards to the BC CDC reporting drug use application, I was wondering if they could explain the advertising on why they felt it would work for street and trench population, and if there's more of an analog version. I guess the question was, might be on the radar. Sorry, I'm not sure if most of those who might be on the radar are using the application. It sounds like it requires a smartphone and thereby a credit card linked to an app store. And from the presentation, it sounds like it would be creating an additional barrier for the user.
Yeah, thanks for the question. And as I said, this is rolled out as of May, and certainly it's been a learning process. And it's a private company along with the BC Emergency Health Services that have worked together on this. In addition to it being available, there have been phones, free phones going out to people who need them. The rollout and the information has been going through each of the health authorities, and especially through their harm reduction organizations. So rather than it being a provincial rollout, it's being rolled out in each of the health authorities using the resources and the community action teams to make it available. So, and as I said, it's the BC Emergency Health Services that really pushed this forward, but are sharing the information and the learnings with everyone as we go along.
Thank you.
And I think it's important to note too, a lot of people that die alone and may not be essentially that street and trench population. So a lot of the people are males that are working or in and out of recovery and are housed and have access to a phone and a computer. And there are a lot of the ones that are dying from overdose deaths. So I think, this is going to be a way to reach a population that historically have never been reached through harm reduction organizations or safe consumption sites or overdose prevention sites.
Thank you for the clarification on that one. I guess one of the questions that I received was the Lifeguard app is just specific to BC. Is that right, Jane?
Yes, but I'm aware of ongoing discussions. There's no reason why it shouldn't be made available elsewhere. So, and I know that the person from BCEHS has had discussions with Alberta and other jurisdictions. So yes, that is something that is ongoing and can be rolled out. And really, as Matthew said, it's important that we have different tools and resources because this is a very wide-ranging population and we need to find something that really helps everyone. It's not for everyone, but this will be a certain population that perhaps is not being reached in our usual ways or may not be as willing to use overdose prevention services even if they are available.
Definitely. A couple more questions here. The person wrote, I'm curious whether combining illegal drug use with the use of alcohol is ever checked by coroners or by researchers. Notice, this is especially dangerous with benzos and opioids. It is not checked. Why not?
It certainly at the coroner's and medical examiner level, it is. It is identified, and with various surveys, it's also asked. So it is a component there. And it does add, as the person who put forward the question, it does increase the risk, especially with benzos, to reduce the respiratory rate and cause an overdose.
Perfect. Thank you so much, Jane. I have one last question for everybody. Have you detected a spike in precursor presence within tested samples across both period pre-COVID and during COVID pandemic?
I can answer this one from Toronto. So yeah, that was kind of in that really messy graph slide that I had there. One of the lines was about inactive fentanyl related drugs. So those being fentanyl precursors. So these are impurities found in fentanyl preparations. We generally see fentanyl precursors or inactive fentanyl related drugs in 50% of expected fentanyl samples. So we haven't really seen an increase since COVID, but certainly they're kind of always there at 50%. The main ones we see are despropanol fentanyl, 4-AMPP, and norfentanyl, and then fentanyl hydroxy.
One last question. Given the effects that COVID has had on substance use, what degree of influence does the increasingly toxic illegal drug supply have in terms of the increased overdoses and overdose deaths relative to other measures? Would you consider the increasingly toxic supply as being the main contributor for increased overdoses, or is it an equal measure of contributors?
From my perspective, I would say it is the toxicity of the drugs is the problem. People will come up with other suggestions that may be contributing, but it's this toxic supply of unknown substances that is causing the deaths.
Toxic supply and the stigma and discrimination of people who use drugs that won't access the services that could be life-saving for them.
And it looks like we've covered all of our questions. Speakers, are there anything else you'd like to cover before I wrap up?
It's Jane. I think there was a number of questions around indigeneity and the fact that what I presented was around First Nations people and did not include Métis and Inuit. And what I'd like to sort of point out is that we were using administrative data for the overdose events and overdose deaths, which does not collect indigeneity. So it has to be identified through data linkage, and it was our First Nations Health Authority that was able to, with support, link and determine that. We do ask around self-identified indigeneity, First Nations, Métis and Inuit, but we do not analyse on that, but that data is available if there are, and we have shared with First Nations Health Authority, but it is there.
Thank you, Jane. My apologies for missing that one. Matthew, Karen, anything else that you wanted to add? No, perfect. Okay, well, great. Thank you, everybody. Again, we appreciate you being here, taking the time to join us. We've had a full house today. Thank you again for joining us, and have a great afternoon.
Thank you.
Thank you.
Thanks for the opportunity. Bye.
Thanks so much.